अस्सलाम वालेकुम टीन स्टूडेंट्स। इस लेक्चर में हम सैक्रल स्पाइन के बायोमैकेनिक्स के बारे में बात करेंगे। इससे पहले जो है हमने बायोमैकेनिक्स ऑफ लंबर स्पाइन की स्ट्रक्चर, फंक्शन और उसके मसल के बारे में डिटेल से बात की। अब हम डिस्कस करेंगे बायोमैकेनिक्स ऑफ द सैक्रल स्पाइन। तो सैक्रल स्पाइन के इनर्ट में डिस्कस करेंगे, इसके डिफरेंट पार्ट डिस्कस करेंगे, इसके काइनेटिक्स, काइनेमेटिक्स, जो न्यूटेशन एंड काउंटर न्यूटेशन है, इस पर इंशाल्लाह बात करेंगे। और इसके अलावा जो हम पेल्विक इनलेट, पेल्विक आउटलेट है, वो भी हम यहाँ पे डिस्कस करेंगे। सो अगर हम सैक्रल स्पाइन की बात कर ले, सो एक्चुअली sacral spine जो है ये it is fused vertebra which is made of 5 sacral segments, and this is actually a triangular structure, a wedge-shaped structure, and this entire structure, this 5 segments which are fused together, this is actually known as the sacrum. This is present between the lumbar spine and the coccygeal vertebra. The base of the triangle, which is formed by the first sacral vertebra, articulate with the inferior facet of the last lumbar vertebra through the two articular facets, and that actually the joint between the first sacral vertebra and the L5. This segment is actually known as the lumbosacral segment or the L5S1 region. The apex of the triangle, which is actually the bottom of that apex, the lowest part of that sacrum, the pointed part or the narrow part of this sacrum triangular shape, that is actually the lower end, and this has been attached, articulate with the coccyx, which is also known as the tailbone, the end of the vertebral column. This is the structure of the interior view of the sacral spine. We can see here in the top, this is known as the sacral promontory. This is the interior superior margin of the S1 of the first sacral vertebra. बेसिकली प्रोमोटरी जो है उस ये थोड़ी सी ड्राई एरिया को कहते हैं, जो वो सी में, समंदर में थोड़ा सा जो ये राइज आपको जैसे नजर आ रही है, सो दैट राइज, ये जो चट्टान होते हैं पानी के ऊपर से इस तरह ऊपर आ जाते हैं, ऊपर जो प्रेजेंट होते हैं, या वी कैन से इस तरह कह सकते हैं कि दैट आउटग्रोथ ऑफ दैट रॉक्स इन द सी, दैट इज एक्चुअली नोन एज प्रोमोटरी। तो यहाँ पर भी इस तरफ देख सकते हैं कि ये एरिया थोड़ा सा जो है बाहर की तरफ आया हुआ है, दैट्स व्हाई दिस इज नोन एज द सैक्रल promontory. दिस इज एक्चुअली द एरिया जहाँ ये L5 के साथ जो है ये जॉइंट बना लेता है, और साथ साथ these are the two articular processes, the left and the right superior articular process, and they make the facet joint with the inferior articular process on the both sides with up the L5. These are known as the sacral wings, are also known as the ala. They are the interior part, they are the lateral part of this broad area, broad section of this triangular shape sacrum. These are known as the transverse ridges, and actually these are the point which can act as a boundary between the two segments. So this, the topmost transverse ridge is at the boundary between the S1 and the S2. This transverse ridge is present between S2 and S3, and so on. So there are 4 transverse ridges which divide the entire sacral spine into sacral vertebrae into 5 fused segments. And these 4, they are the anterior sacral phenomena on the both sides, which provide an exit point for the sacral spinal nerve. This is actually the bottom of the sacral spine, the apex of the sacrum, and that actually articulate. This is the S5, and that articulate with the coccyx, the tailbone of the vertebral column. This is the posterior view of that sacrum. This is the sacral canal, which is actually a continuation of the vertebral canal, and it houses much part of the that inferior end, which is actually a bunch of nerves of the spinal cord. These are the superior articular facet on one side and the left and right, and these are the concave shaped articular surface, where the convex surface articular surface of the inferior left and right but articular process of the L5, they articulate here. These tear drops like structure, these are the modified sacral spine, and we can see these are known as the spinous tubercle, which are actually the spinous process of the fused sacral vertebra. There are three crests: the lateral crest, the intermediate crest, and the medial crest. This is the medial crest, sacral crest, and that is actually the midline, and that marks the dorsal midline of that fusion of the that sacrum. This line, actually, this line is actually known as the medial, yeah, the intermediate sacral crest, and this line actually known as that zigzag. This line is known as the lateral sacral crest. So the lateral sacral crest, the intermediate sacral crest, and the median sacral crest. On the other hand, on the other side, there are also the intermediate sacral crest, and this one is the lateral sacral crest. These foramina on the posterior side, they are known as the posterior sacral foramina, and they allow for the passage of the sacral spinal nerves. That empty area, that is actually known as the sacral hiatus, that is the terminus of the spinal canal, and these two area, these are known as the sacral cornu, which cornu mean the horn. So these two are also known as the left and right sacral horns, and they articulate with the coccygeal cornu. These are the two coccygeal cornu or the coccygeal horn. They make joint with each other, which give also a point of attachment for the various muscles. So this is actually the osseous structure of the, this is the posterior view of the sacral spine. The sacroiliac articulation or the sacroiliac joint, the two sacroiliac joint on the right and left side, that is the joint between the left and right articular surface of the sacrum, which are actually formed by the partially by the first and third and completely by the second. So we can say that these this that ear shaped auricular surface of the sacrum, that is made by the first, second, and third segment. All of them, they have contribution at that articular surface, and the left and right iliac moves. The SIJ, the sacroiliac joint, that having unique characteristic that it changes in structure and function from birth to adulthood. And what is that change? Actually, in the adult, in the childhood, these are actually the smooth surfaces and they glide with each other. The auricular surface of the sacral spine and the iliac, they just glide on each other. They're just plain gliding joints. But later on in the adulthood, यहाँ पे जो है आउटग्रोथ और डिप्रेशन जो है आ जाते हैं, और डिप्रेशन जो है ये सेक्टर सरफेस में फिट से बन जाते हैं, जिसमें इलियक की जो आउटग्रोथ है ये बिल्कुल फिट उस फिट्स में आ जाते हैं, एंड दैट्स वाई यहाँ पे फिर वो ग्लाइडिंग नहीं होती और दे जस्ट फिक्स. और यही वजह है कि सेक्टर जेड की मूवमेंट जो है बहुत रिस्ट्रिक्टेड मूवमेंट्स होते हैं. इस जे मूवमेंट्स यहाँ पे मूवमेंट इतनी नहीं होती, दे बोथ आर फिक्स. So the sacral spine, so you can say that in the childhood, the both sacral and iliac surface are smooth, which allows some gliding movements. But in the adulthood, because of the outgrowth on the iliac surface and the depression and pits on the sacral surface, they just come in fit with each other, and that's why there is no more gliding movement. The sacral auricular surface, they are C-shaped and are located on the lateral surface of the fused sacral vertebra, lateral to the sacral foramina. The fetal and the prepubertal surfaces are flat and smooth. Here is the post-pubertal surface that are marked by depression that spread all over the articular surface of the sacral articular surface. This ear-shaped structure is actually the sacral auricular surface or articular surface, which is made by the S1, S2, and the S3. The same structure, the same resembling auricular ear-like structure is present also on the iliac surface, and they just make the SIJ. It is known as the auricular surface because auricular, that means resembling to the shape of the ear, human ear. The iliac articular surface of the SIJ joint, and this is again the C-shaped, also the ear shape known as the auricular. So the iliac auricular surface and the sacral auricular surface. In first decade of life, the iliac joint surfaces are smooth and covered with cartilage. After the puberty, the joint surface develop a central ridge that extends through the length of the articular surface and correspond to the groove on the sacral spine. So that is actually the auricular surface of the iliac spine, which resemble the human ear. So and this surface of that iliac that make the joint to the auricular surface of the sacrum, and this junction between them is known as the sacroiliac joint. We are not concerned with other detail of this innominate bone or this pelvic bone, so that's why we are going to skip all this process, which is actually the ischium and the pubic bone and the ilium. The ligaments and the interior view of the sacroiliac ligaments, they are the sarcospinous ligament, the sarcotuberous ligament. These two ligaments are very important. The sarcospinous ligament, they is shorter and as compared to the sacrotuberous ligament. And why they are known as the sacrospinous ligament? Because this is actually from the sacrum to the pubic spine. On the other hand, sarcotuberous जो है, this is from the sacrum to the ischial tuberosity. So that's why these two ligaments are known as the sarcospinous ligament and the sarcotuberous ligament. Similarly, there are the two interior sacroiliac ligament as well as the lumbosacral ligament. This interior sacroiliac ligament is one of the main stabilizer of the sacroiliac joint along with the lumbosacral ligament. On the posterior side, the sacroiliac ligament, there are two types just because some fibers they are shorter in length and the other are longer. So the shorter one they are known as the short posterior sacroiliac ligament and the long posterior sacroiliac ligament. And these two ligaments they provide stability and the posterior side to the sacroiliac joint. While the iliolumbar ligament that is not concerned with the stability of the joint, the reason is that joint is present between the transverse process of the L5 and the iliac, so they're not concerned with the sacroiliac joint. The other two, the sarcotuberous and the sarcospinous ligament, so it means the interior and posterior sacroiliac ligament along with the sarcospinous ligament and sarcotuberous ligament, these are the ligaments of the that sacrum on both the interior and posterior side. The next is the lumbosacral angle. We have discussed this topic, this lumbosacral in the lumbar spine biomechanics example. But as this angle is between the lumbosacral segment, so it means this is being as we have discussed in the lumbar spine, but it will be also discussed here in the sacral because this lumbosacral angle is concerned with both the L5 and the lumbar spine as well as the sacral spine. So lumbosacral angle is determined by the drawing one line parallel to the ground and another line along the base of the sacrum. This is usually that horizontal to the dead ground, one line, and the other line, just the disc present between the L5 and S1, the lumbosacral. So as we know that we have discussed in the lumbar spine biomechanics in the structure that the L5 is a wedge vertebra, and because of the wedge, the disc is also wedge shaped, that is obliquely present. So that line which is passing through the mid of that disc present between the L5 and S1, and if the angle which is made by this oblique line with the horizontal imaginary line, so this angle is actually known as the lumbosacral angle. This angle will increase as the pelvic tilt anteriorly and decrease as the pelvis tilt posteriorly. So there is a direct relationship, a positive relationship between the lumbosacral angle and the anterior pelvic tilt, while there is indirect or the negative relationship between the posterior pelvic tilt and the lumbosacral angle. Similarly, there is also a direct relationship of the lumbosacral angle with the lordosis. So if there is a direct relationship, mean if there is too much lordosis, which means there will be increase in the lumbosacral angle more than normal, and if there is high lordosis situation, when the lordosis is there is less lordosis than the normal, then they will be also decrease in the lumbosacral angle. So higher the lordosis, higher the lumbosacral angle would be. The normal value of this lumbosacral angle is 30, so it means when there is hyperlordosis, the angle will be more than 30, and if there is hypolordosis, when the lordosis is absent, when the lumbar span is straight, or when there is less lordotic curvature, then the angle will be less than 30 degree. So as the lumbar lordosis increases, the angle increases. So it means there is a direct relationship of the lumbosacral angle with the anterior pelvic tilt and the lumbar span, lumbar region, lumbar vertebra lordosis. This caused the shearing stress of the L5 and S1 to increase, and forward movement of the L5 and S1 is prevented by ligamentous support. The shape and fit of the inferior articular process of the L5 inside and behind the superior articular process of the S1. Conversely, as the lumbar lordosis decreases, the lumbosacral angle also decreases. So that is actually the situation which we have discussed in the previous two slides. Here, this is the normal situation and the normal lordosis. So that's the angle is 30 degree. Here we can see here there is not only increase in the thoracic kyphosis, there is also increase in the lumbar lordosis as well. और जिस तरह यहाँ पे lordosis जितना increase होगा उतना ही जो है ये एंगल, क्योंकि obviously जब lordosis increase होगी तो ये जो obliqueness है ये और भी ज्यादा हो जाएंगी, ये और भी टुवर्ड्स मतलब हॉरिजॉन्टल से ज्यादा वर्टिकल की तरफ जाएगा. सो जितना वर्टिकल जाएगा उतना ही ये लाइन जो है ये भी उसके साथ ऊपर जाएंगे, एंड हेंस this angle will be increased in magnitude. So in this case, this angle is more than 30 degree. And the other case, we can see here the lordosis as compared to this normal situation. Here, the lumbar lordosis has been decreased, and there is much we can say that a straight lumbar spine. Here, the straightness of the lumbar spine will bring that disc more towards the horizontal side, and hence the line passing through the disc between the L5 and S1, and they will be near to the horizontal, and hence the angle will be decreased. The magnitude of this angle is now less than 30 degree, because here we can see this is the hypolordotic posture situation, and this is actually the hyperlordosis, and this is the normal lordosis. The SIJ, if we talk about the kinematics of the sacroiliac joint, so the sacroiliac joint, they permit small amount of motion that varies among the individual. And why there is small amount of motion, just we have discussed previously. In the childhood, there may be some movements, gliding movements, but in the adulthood, because of that ridge and the iliac surface, auricular surface of the ilium, and the depression and pits in the auricular surface of the sacrum, because of these there is no gliding movement, and hence there is very less amount of movement at the SIJ. The SIJ, they are closely linked with the symphysis pubis. That's why the movement occur at the SIJ are accumulated by the that symphysis pubis joint and vice versa. So two moments which we will discuss in the next slide, that is nutation and counternutation, that occur at the sacroiliac joint. The nutation, that is also known as the sacroiliac joint flexion, and the counternutation is known as the extension of the sacrum or the SIJ. The plan articular surface in early childhood allows gliding movements in all directions. However, after puberty, the shape of the articular surface they are changed so that the movement quality also changes. What is nutation? That is the sacral flexion, and it occurs when the base of the sacrum and the superior end, which is actually the promontory, that moves interiorly and inferiorly. That is actually known as, this is nutation when the superior top surface of the sacrum that not move only interiorly but also in the inferiorly. So we can see here there is actually interior tilting as well, or in somehow if there is a bending of the lumbar spine, so that will also bring some nutation in the sacral region as well. So this causes the inferior portion of the sacrum and the coccyx to move posteriorly. So these both definitions are correct. In nutation, when there is posterior movement of the inferior portion of the sacrum and the coccyx is known as nutation, or when there is anterior and inferior movement of the top um, of the sacrum, which is known as the base of the sacrum, will be called as the nutation. When there is nutation, actually the pelvic outlet become larger. It's very important. Um, while the pelvic outlet can be described by drawing a line from the tip of the coccyx to the bottom surface of the pelvic symphysis. Here we will, this is actually the pelvic inlet. When there is interior, when there is interior flexion or there is nutation, so there will be the length of the pelvic inlet, they will just shorten because that will much move closer toward the symphysis pubis. On the other hand, the pelvic outlet they will increase because there will be posterior movement. So जितना ये posterior जाएगा उतना ये line जो है ये ज़्यादा होगा. So pelvic outlet जो है ये during the nutation increase होती हैं and pelvic inlet जो है ये decrease होती हैं. On the other hand, counter notation में the base, the top surface of the S1 that moves superiorly, posteriorly, as well as superiorly, and hence the pelvic inlet will increase in size and area, and while there will be shortening of the pelvic inlet. So there is equally the pelvic outlet become larger in the nutation as we discussed in that diagram. The counter notation, also known as the extension of the sacral spine, and that refers to the opposite motion of the nutation. The base of the sacrum moves posteriorly and superiorly, causing the tip of the coccyx to move interiorly. So this is completely, this movement, this kinematics of the sacral is completely opposite of that of nutation. That's why this is known as the counter notation, mean opposite of nutation. The pelvic inlet become larger as and with contrast with the nutation where the pelvic outlet become larger. So in the counter notation, the pelvic inlet become larger, and which is defined as drawing a line from the base of the sacrum across the top of the symphysis pubis, as we have discussed कि अगर हम यहाँ पे symphysis pubis के top से एक line draw करें to the top यानी base of the S1, so that will be called as the pelvic inlet, and the bottom of the symphysis pubis से अगर हम एक line draw करें symphysis pubis से to the tip of the coccyx, so that will be called as the pelvic outlet. So this is the nutation, this is the counter nutation, and this is the pelvic inlet and pelvic outlet. Actually, the pelvic inlet is the boundary between the true and false pelvis. The pelvic area which is above the pelvic inlet, that is known as the false pelvis, and the pelvis which is between the pelvic inlet and the pelvic outlet, that is actually known as the true pelvis. So this is actually the pelvic outlet. This is the bottom of the symphysis pubis, and this is actually the tail, the end of the coccyx bone. So this is actually the diameter of this pelvic outlet. So that was the end of the biomechanics, a short and brief review of the biomechanics of the lumbar of the sacral spine, where we discuss the structure of the sacral spine as well as we discuss the lumbosacral angle and its association with the pelvic tilt, both interior and posterior, and the lordosis, the hyper and as well as the hypolordosis. Then we discuss the kinematics of the sacral spine, the nutation and counter nutation, and as well as we also discussed the pelvic inlet and the pelvic outlet. So that was all about the biomechanics of the sacral spine. Thank you so much to all of you. Have a nice time.